everybody. I'm Dr. Shashank Joshi. I'm an endocrinologist from Mumbai. Right now, I'm in Florence, in Italy, and today is the concluding day of the ATTD meeting, which is the largest global conglomerate and meeting of science and medicine related to technologies related to diabetes management, care, and prevention. And this meeting is in its 17th year. It was born in Prague by two founders, Professor Filip Moshe from Israel and Professor Tad Betalino from Slovenia. And this meeting has grown from a small audience below 1,000 to one of the largest meetings on planet Earth. It's a perfect marriage of doctors and engineers, technologies, healthcare providers, and people living with diabetes. And this is the only meeting on planet Earth which has people across all spectrums of life who are involved in care and delivery of people living with diabetes. The focus is fundamentally diabetes outcomes, and we are looking at people living with diabetes, whether they are in type 1 diabetes space, type 2 diabetes space, obesity, gestational diabetes, or even secondary diabetes, that they have better health outcomes and happiness outcomes. We can see that every diabetes technology and startup as well as pharmaceutical industry is present here in Italy as we conclude the sessions. The session started with the opening plenary with Professor Melanie Davis, who gave us a very cutting edge overview of all the cutting edge single agent, dual agent, triple agents of the 3Gs, which work on multifunctional peptides, which are revolutionizing obesity management and diabetes management, and are working towards the remission space. And she gave a very eloquent oration on the same. And from there, then we moved to the core plenary, which was yesterday, which was on the yearbook sessions. And in the yearbook sessions, the brainchild of one of the Indian alumni from PGI Chandigarh, who migrated to United States at the Barbara Davis Center for Adult Diabetes, Professor Satish Garg, gave a very cutting edge, eloquent view on new medications in treatment of diabetes. And he, with Professor Earl Hirsch and Avanda reviewers, talked about the 3Gs, the single, twin, and triple GLP-1 agents, the GLP-1, the GIP, and the glucagon receptor agonists. And these are very effective on glucose control. They reduce body weight, they improve cardiovascular outcomes, and also improve kidney outcomes. And whether it is the oral GLP-1, GIP-1 agent, which is a new designer drug, or the multifunctional drugs like the cotatudide, the retatrutide, which are coming up in the near future. We also now know the first oral non-peptide GLP-1, which has a low activation of the beta-arrestin pathway. The ofragliflozin data was presented by him. Then, of course, the first trial which he was himself responsible was the efficacy of semaglutide in type 1 diabetes and on weight loss, as well as the tirzepatide in type 1 diabetes. So clearly we recognize one thing today in diabetes care, that virtual care is here to stay. And therefore, I will just talk a little bit about what Professor Garg talked about virtual diabetes care clinics. But there are the twin and triple cretins. The incretin name now has become twin-cretin and triple-cretin. And they have compelling weight loss, which will make bariatric surgeons out of market. Of course, bariatric surgery for morbid obesity still has a role, but these compelling twin-cretins and triple-cretins will have weight loss, which will move the handle from 10% to 20% to up to 40%. They will not only improve glycemia, but achieve diabetes remission and also liver disease remission. And of course, we have oral agents in that, and when we have, of course, a tirzepatide for weight loss approval, and also they have a role in type 1 space. But what happens is, when you lose weight, you also lose muscle mass, and when we lose muscle mass, then sarcopenia becomes a huge concern, and therefore we need to ensure that the proteins are appropriately supplemented, and that's something which we need to look at. Resolution of type 2 diabetes is a reality today. In fact, I work in this space on diabetes remission, which I am speaking today on, and I will come back to that on in a little later. But bariatric surgery is under huge threat. Virtual clinics got the epicenter from the pandemic, and Professor Garg again very nicely alluded to that and clearly recognized that telemedicine, whether it is obesity, whether it's diabetes retinopathy, whether it's pregnancy care, became the epicenter. So in the obesity space, with virtual obesity clinics, we can not only improve weight and BMI, but also look at remission of type 2 diabetes space. With the deep learning AI models today, we can ensure that we can detect, diagnose, and ensure that retinopathy can be picked up and they can be redirected to specialists for care and save vision. And pregnancy and virtual clinics have become also a standard of care, particularly in the remote access area. So, remote medicine is a standard of care. Dr. Viral Shah, who used to work with Dr. Garg and has now moved to India now, also gave a very nice summary of 5 cutting-edge trials in obesity space and 5 cutting-edge trials in the MFLD space. And clearly they recognize that in these trials, the D-Elite trial, which was RCT, which was remotely done for weight loss, was not as compelling. Lifestyle is there, it works, but drugs like the GLP-1 single agent like semaglutide or dual agent like tirzepatide have clearly changed the biology of the disease. Similarly, if you look at the MAFLD space, again we have lifestyle. Lifestyle works, and we have published a paper in endocrine practice last year where with the digital diabetes twin remission in 1 year RCT we have demonstrated that we can achieve diabetes remission. Similarly, these agents work, but now we have SGLT2 inhibitors in this space which chop off and shave off the liver fat. Similarly, we have GLP-1 receptor agents which chop off and shave off the liver fat. So, they are here to stay. Then of course, the whole roadmap of artificial intelligence was beautifully highlighted yesterday by the founder of this conference, Professor Tad Batalino, and he gave us wonderful examples of not only using machine learning models for diagnosing people and identifying cohorts in people living with type 2 diabetes, but looked at the various models from the manual curation to risk trial profiling. And clearly with precision diabetes care, using machine learning models, we can do a very elegant cardiovascular risk reduction. In fact, such proof of concept studies were highlighted by Professor Tad. And you see, the point is that we are looking at a model where we are integrating and assembling artificial intelligence technologies which are locally adaptable and developing neural networks for the same. So, this is not easy at all. And in the retinopathy space, the AI and retinopathy framework has been not only cost effective. So, one has to identify what is artificial intelligence, what is machine learning, and what is deep learning. And in my talk also today, I am exactly highlighting the same in the diabetes care space. So, clearly we have a clinic which is physical space, and then we have a cloud, and the clinic to cloud interactions and the marriage of the two is something which we need to synthesize, process and deliver, and it has then to be personalized and individualized, and that is what cutting edge technology is doing, and we are trying to see what is the best fit model for that given individual. For example, using AI, we can actually look at the arterial Doppler waveforms, and that can actually decide whether the person living with diabetes will have an adverse outcome or not, and that is clearly possible now. We can predict death, the MACE, the male outcomes, and using deep neural networks by Doppler lower limb testing on peripheral arterial disease, we can actually predict many of these outcomes. Also, in screening of type 1 diabetes, we can use publicly available data, particularly from large databases from high dense type 1 geographies like Scandinavian countries, and the Swedish innovation agency, the Vinnova, they have this ASSET consortium, which is the AI for sustainable prevention for autoimmunity in society, and the ASSET healthcare funded by the Swedish innovation agency to predict a type 1 diabetes, because the whole idea is to predict type 1 diabetes. If we can screen, you know that in a country like Italy, every 2 years, after birth, they are screening everybody for an antibody, and that is a universal screening. In north of Finland, there is a high prevalence, in Sweden, in Denmark. So, in high prevalence countries, they are doing antibody screening because now we have treatment options. So, in screening of type 1 diabetes, not only for risk stratification, for individualization, for optimization of resources and cost effective care, but predictive biomarkers, AI is now being tapped. So, to improve individual prediction and enabling personalized management, it is here to stay. Also, we have a lot of data from the FASA study. And the FASA study clearly shows us that even for screening for type 2 diabetes mellitus, we can utilize this data for better prediction modeling, and clearly for men and women both, we can ensure that. So, clearly AI in diabetes management is here to stay, and it can improve care, it can increase personalization, increase success of therapy, and shorten and standardize decision pathways and support screening. No, but there are always challenges. There are roadmaps, but roads will always have blocks. For example, food cooked in every global household is different. and we have different inputs of food. So the nutritional content of a meal image, like the Go Food program, is very different. That was being discussed. Then there are challenges of time needed to eat, how fast you eat, what is the satisfaction of food, and then of course we have smartphones. Now, can smartphone applications prevent type 2 diabetes? There's a very beautiful analysis by Lorenzo et al., which have actually looked at every smartphone app to prevent type 2 diabetes in a meta-analysis. And clearly that has recognized this guideline. So when you see AI driven clinical decision support systems, we need to have a mechanism of assisting both healthcare workers and people living with diabetes and create a roadmap in that direction. And such work is happening in Europe, in the European Diabetes Forum. And they are looking at how to develop and make this data for integrating the healthcare system with people living with diabetes using a lot of reasoning, artificial neural network, machine learning, and artificial intelligence for people living with diabetes. But there are challenges like privacy, by like regulation, by human factors, cost, and data exchange and data standards. So obviously there are different steps, and it's a long question to go. So obviously when we are looking at roadmaps, you need to code it, you need to have an open standardized platform, open and optimal AI algorithms, and ensure that all stakeholders are networked well. So this is something which we all recognize. What I am speaking on today is the role of artificial intelligence in diabetes care. And my predominant role is people living with type 2 diabetes who have adequate C-peptide and who are in their first decade of a diabetic's life, if they are on 2 or 3 agents, by using precision nutrition, precision activity, precision sleep, supervised by a coach, using sensing technology, whether it is a sensor, a weighing scale, a Fitbit, and so on and so forth, using a twin filter of an algorithm by MI learning models, which are developed by scientists from California as well as from IIT Madras Research Park. They are the gurus, and they are the ones who have taught us to do an RCT, how to do diabetes remission, fatty liver disease remission, hypertension remission. And this is not just speculative. Today we are having hard science and we are ensuring that good outcomes. And these outcomes are not just health outcomes. These are outcomes, not just glucose outcomes or liver outcomes or blood pressure outcomes. These outcomes are also mental health indices like happiness outcomes. Because at the end of the day, what is AI going to do? It is not only going to disrupt the way we think, it's already disrupted our lives. For example, mobile phones have disrupted our lives. Similarly, in people living with diabetes, they are enablers, they are empowerers, and they are educative tools so that people living with diabetes can get better healthcare outcomes. They can have an ecosystem where they are connected with their healthcare provider as well as their doctor, so that they have some degree of comfort and security, and also have outcomes which are happier. So ultimately, we are looking at a world which is free from complications related to diabetes. And in that pursuit, our fundamental objective is adherence. And in adherence, I think AI is an excellent enabler. And we are looking at a precision delivery. We are looking at individualization of medicine or personalized medicine. And again, AI is able to give us the predictive maps on, say, a working day, on a weekday, on an off day. Because as human beings, we are always 24/7 changing. Mathematics is not a medical science. In mathematics, 2 plus 2 is equal to 5. But variability is an inherent characteristic of the biological world. So in maths, if 2 plus 2 is equal to 4, in biology it could be 5, it could be 6, it could be 2. So where the handle goes, we all operate on a Gaussian curve, which is the normal curve, which is at 95% confidence limit. And that is where AI will direct doctors to identify various endotypes of type 2 diabetes, responders, non-responders, who will do well, who will not do well, and get us better solutions and better outcomes so that people living with diabetes eventually will have happier and healthy lives.